So I started my career as a doctor. I'm an immigrant, and I was always interested in health. As an immigrant interested in health, the only thing I knew about was medicine. So I went to medical school, and when in medical school I became very interested in becoming the kind of physician who could really practice medicine anywhere, who could serve marginalized and faraway communities. So I did that. I did that kind of residency, that kind of training. And then I practiced medicine in remote parts in northern Canada, in places like Papua New Guinea, Philippines, and particularly in Somalia, working with Doctors Without Borders. So while I was in Somalia, I was the only physician for a population of about 350,000 people. And I was seeing a lot of people who were very sick, and I was trained well. And I like to think I was helping people. I was helping people return to health. And I think I was doing good. I think I was doing a lot of good for the individual patients who I was seeing. But doing this good had a paradoxical effect on me. Rather than saying, I can do more, I can do so much with my hands, I began thinking, but there's something wrong with this, because I'm here, I'm doing good, but I'm doing good in the short term. Eventually I'm going to leave, and someone will come after me, hopefully well-trained as well, but maybe not. And there must be a better way. There must be a way to keep people from becoming this sick to begin with, from being this injured, being this traumatized. This was a fairly volatile environment at the time. So I decided to go back to school and do a training in public health. I did a master's in public health, and eventually I did a doctorate. And in many respects, I found my calling there. And I would consider my calling really to be in this enterprise of creating health, generating health, maintaining health, preserving health, and really trying to be part of an enterprise that makes populations healthy. Now, at this point, the one question which I'm often asked is, well, what is public health? Well, what does it mean to be part of an enterprise to make populations healthy? And I suppose the best way I know how to answer that is by story, is by telling a brief story. And this is a story of a famous blues singer. His name was Blind Willie Johnson. So Willie Johnson was born around the turn of the 20th century, and he was born in the Mississippi Delta, one of the poorest parts of America. And the story has it that the reason he was blind is because when he was 3, in an episode of domestic violence, he had lye thrown in his eyes, and as a result he was blind. So he grew up a black, poor, blind, in a very poor part of the country. He made his living essentially through his music, through his blues singing, and he was living in a fairly poor house, and eventually he developed malaria, and he died. His wife at the time said that that Blind Willie, she took him to hospital, and he was turned away from the hospital, and it's not clear whether he was turned away because he was poor or because he was black. So the story of Blind Willie Johnson, I tell it to illustrate what the remit of public health is and what we should be caring about if we want to create healthy populations. So malaria matters. Obviously, Blind Willie Johnson died of malaria. So malaria is a concern. But he didn't just die of malaria. He also died of poverty. He also died of racism. He also died because he could not access healthcare. Those are all the concerns of public health, and those should be the concerns of anyone who cares about making populations healthy. In this country, the Blind Willie Johnson story, I think, illustrates one of the core paradoxes that I think the United States deals with on a regular basis. And the paradox is as follows. We care about health. We care about health, one shouldn't take my word for it, but just based on the fact that we spend more money on health, far more money on health, than any other high-income country, easily 30% more. So you'd say we're putting our money where our mouth is, we care about something, we'll spend money on it. There's nothing wrong with that. But despite how much we spend on health, we have far worse health outcomes than any other peer country. Now, I'm not comparing us to very poor countries. That's not a fair comparison. But comparing us to other high-income countries, we are at the bottom of the barrel in terms of our health outcomes, in terms of our health indicators. Now, why is that? Well, I come back to the story of Blind Willie Johnson. The reason that is because we do spend money, but not on health. We spend money on medicine, mostly on curative medicine. To go back to the story, we care about the malaria, but we forget that the malaria by itself is not what killed Blind Willie Johnson. The malaria killed him, but so did his poverty, so did his race, so did the violence and trauma that he experienced in childhood. So to create health, we need to pay attention to the full range of factors. We need to make sure that we spend money on the full range of factors. And the data are very clear. We overspend quite a bit than everybody else on medicine, on curative medicine, and we underspend by quite a bit on all the other forces that ultimately shape health. I wrote this book, Healthier, 50 Thoughts on the Foundations of Population Health, really as an effort to illustrate these other ideas, to make the point that these other factors matter. There are chapters on racism, there's chapters on housing, there's chapters on trauma, there's chapters on health of marginalized populations, there are chapters on the difficulties faced by LGBTQ populations. Because these are all factors that matter if we want to promote health. These are all factors that matter for the health of populations. And frankly, anyone who's interested in the business of generating health, promoting health, which is what I said I've been interested in since I shifted from clinical medicine to public health, I think needs to consider these factors. One of the things that this has led me to is a concern with how we collectively spend our money and our focus as a society. And one of those foci recently has been precision medicine, has been the enormous amount of effort spent on getting ever better at molecularly and genetically identifying specific diagnostic as well as treatment approaches. And I'm an enormous fan of precision medicine approaches. I actually think this has tremendous potential for discovery science. And I'm very much supportive of the intellectual agenda behind precision medicine. My concern is not that. My concern has been a concern that if that is what all we're putting our resources in, we are putting all our eggs in a curative basket, and that is ultimately not going to promote health. That ultimately we need to pay attention to the breadth of factors that promote health, and by we, I mean those of us in research, those of us in education, those of us who are funding research, and at the national policy level. When we think about health, these kind of decisions, like investing in precision medicine at the expense of other factors, reinforce a misconception that we have in our society. And that misconception is that, well, if I'm healthy, if I look after myself, I'm going to be fine. I'm going to be okay. And the answer is yes, you are definitely going to be much better than if you don't exercise. You're going to be much better than if you overeat. But we forget that many of the forces that ultimately determine our health are outside our control. So for example, infectious disease, lower immunization rates means you and your children are more likely to get infectious disease regardless of your immunization status or not. Trauma and violence are likely to affect us whether we're involved in them or not. Good 10% of all pediatric motor vehicle deaths are not kids in cars, they are innocent bystanders. These are things that affect us whether we like it or not. We have data now that shows that our behavior, for example, whether we overeat, is determined as much by our networks as it is by ourselves. Patterns of things like alcohol drinking, over drinking, are determined by our network and by the availability of alcohol. So unless you think you can wrap yourself in bubble wrap and insulate yourself from all social influences and from all potentially adverse influences in your social, economic, cultural environment, our health is all dependent on the world around us. You know, I tell the story best through a metaphor, I think, which is a metaphor of a goldfish. So imagine you have a goldfish in a bowl, and you like this goldfish, and you want the goldfish to be healthy. And you say to the goldfish, in order for it to be healthy, I want you to exercise and to swim around your bowl 10 times clockwise, 10 times counterclockwise every day. And you say to the goldfish, when you get the little flaky food on top, don't eat too much so you don't get fat. And you say to the goldfish, if you have a goldfish companion, make sure you have safe goldfish sex. And if the goldfish gets sick, you get the best goldfish doctor. And you do all these things, and one day the goldfish still dies. And you say, well, how could it be? It didn't eat too much, it was careful in its relations with other fish, it exercised, how could it still die? And then you realize that you forgot to change its water. The water around us influences everything we do. And unless we change that water, we are not going to create the healthiest goldfish, no matter what we do to the goldfish itself. So it takes me back to my initial story, the initial story of a blind Willie Johnson. That Willie Johnson died of malaria, but even if the hospital had treated his malaria, he was going to die of something else soon after anyway. He was a poor black man in Mississippi who really had no access to the resources that could create a healthy life. It was only a matter of time before some pathology ended his life. So for anyone who's interested in the arc of generating health, we need to care about the water, about the goldfish's water. We need to care about the built environment. We need to care about homelessness. We need to care about income gaps. We need to care about racism. We need to care about forces that generate hate. We need to care about marginalized populations that in and of themselves are vulnerable, but also can change disease dynamics. These are all forces that ultimately matter. These are all the factors that we need to improve if we want to create the healthiest goldfish. So one of the areas that I've done a fair bit of research on has been the consequences of trauma and violence, mostly on large scales in terms of war and after large-scale traumatic events like disasters. And we talk a lot about war, and lately, unfortunately, there's been a lot of careless talk, I think, about war and particularly nuclear war. And it really elides the truth about war and conflict and trauma, that ultimately it has enormous human cost. That large-scale traumatic events, be they human-made like war or natural disasters, result in vast numbers of people who are injured in the short term, and that's what we tend to think about, but even more people who then end up having mental health consequences of the trauma and of that war. And that is, to my mind, one of the great unspoken tragedies of any conversations about war. So I actually talk a little bit about war in my book, not because it's something that happens every day, mercifully, but because it is such an extreme example of when we neglect to focus on the core fundamentals that create healthy populations, and war is the ultimate abrogation of that. One of the insights that I think emerges when one thinks about population health, one thinks about generating health in populations, is that there's no one thing that causes the health of populations. That requires a whole set of factors. And at the level of concept, in some respects, that's not so hard. It becomes even harder, though, at the level of analysis. How does one wrap one's brain around this analytically within one's research and scholarship? It's to that end that I did this other book called System Science and Population Health, which really is about saying, how can we take a system science approach to solving these issues? How can we use system science approaches, which is a full range of approaches that take into account system heterogeneity, interrelationships, dynamic feedbacks, discontinuities, phase shifts, all characteristics of complex systems, but also all characteristics of populations. How can we take those factors into account analytically through a particular analytic approach? And I think system science methods give us an opportunity to do that. And it's not so much the method, although there are particular methods, things like agent-based modeling or discrete stochastic models, but as much as the perspective, as much as the lens, as thinking about and recognizing that these are complex systems and we need to take into account the full range of factors so we can understand what are the key manipulable factors that can make a difference. I think there are two key conceptual perspectives that really inform how we can think about how health is produced. One of them is called the multi-level perspective, and what that means is that my health is determined not just by me, but also by the people around me. And the health of all of us is determined by where we live. And the health of where we live is determined by the policies of the place where we live. And the policies are determined by the national, cultural, and economy and politics. So just to give a concrete example, I may get lung cancer because I smoke, but I smoke because my friends smoke. We smoke because we live in a marginalized neighborhood with frankly no other source of pleasure. We live in such a neighborhood because of policies that enshrine gaps in income, and that happens because that is a value that we accept at our society. So that's the nested multiple levels of influence. The other perspective is called a life course perspective, which is that my health as an adult at this point is a product of my life all the way from perinatally, conception, even preconception, as well as intergenerationally. And perhaps the best way of thinking about that is by thinking about the circumstances of your birth. That I understand in the American conversation, which privileges this notion of autonomy and the fact that we can determine our own fate and our own health, I get that, but it's hard to argue that any of us have done anything to deserve where we are born. Where we're born is a matter of luck. And where we're born and how we're born and the circumstances of our birth matter enormously for our health. At a very simple reductionist level, if we are born in a context where our mother was exposed to perinatal toxins and we're born with a deformity, that is going to set the course for our health for our entire life. At much subtler levels, being born in an environment where one's parents are stretched and as a result there is trauma or violence in the household, which we know is deeply affecting of subsequent mental disorder and mental health over the life course, that matters tremendously in terms of shaping our health. So our health today, one's health as an adult, is not a snapshot of just what I do today. It is an accumulation of forces that I've experienced over life course. This is why, for example, things like flint matter so much, because when you have children who are exposed to toxins, that's going to matter throughout their life course. This is why if I were to have a choice about one particular investment that I would make, it would be to ensure as healthy as possible early childhood development, because that is going to yield more return on investment for society than anything else I can think of. The science of resilience, resilience by definition is you're exposed to a traumatic event, you're exposed to hardship, and then you bounce back, is actually quite a rich and deep science. It comes from engineering, about materials that are resilient to stressors, but it's been applied now to humans quite a bit. And we know that some people are resilient, some people indeed do bounce back, but we also know that not everybody does. And the key factor in bouncing back, as far as I'm concerned, is the burden of the trauma experienced. In that the people who experience trauma throughout their life have a harder and harder time bouncing back, because frankly they're shifting ever away from the norm. So yes, we can bounce back, and I often feel in the public narrative we make a real virtue out of saying, oh, look at this particular example, she had such a tough life and then she was still okay. But we have to remember that these are the exceptions, that for most humans the more trauma is experienced, the harder it is for them to bounce back and to get back to normal health. So children who have experienced malnutrition, for example, or children who have experienced perinatal toxins, some of them can bounce back. It depends. It depends on the amount of perinatal toxin, it depends on the malnutrition, and some of them will have latent health effects throughout their life course when they're adults. There is no question that genetics plays a role in determining human health, no question. What I think has been a misconception is that we think that genetics is everything. Genetics is not everything. It is just one very small piece of the puzzle. It's not a blueprint on which we build a building. It is rather a rough guide, and the expression of our genes that is determined very much by our experiences in utero all the way through our life, all the way to our end of life. So the mistake, if there is any mistake that we've made on genetics, is the thinking that it's everything. And this is not the fault of geneticists or people who study genetics. People who study genetics are very sophisticated about these things, and they understand that this is just one piece of a larger puzzle. But I think we have failed in the translation of this. And in the public conversation, genetics frequently is portrayed as the blueprint on which we build everything. It's far from the case. Genetics is just one piece, just as much as is our entire lived experience. I'll use one aphorism. This is not my story. I read it from a colleague. Are there genes that are associated with obesity? Absolutely. Absolutely. There are some people who are more likely to be obese than others. But here's the point. The point is that saying that our obesity is due to our genes is like saying that the reason we drown is because of genetic factors. Of course, we drown because we don't have gills, but we don't drown because we don't have gills. Of course, we drown because we are in water in conditions that don't let us swim. But do genes matter? Of course they play a role, but they are just a very small part of the bigger picture. And we just need to keep that in mind. We need to keep in mind that yes, genetics can result in some predisposition, but ultimately the reason for the epidemic of obesity in this country is not genetic. Our genes haven't changed in the past 30, 40 years. It is a change in our dietary patterns and availability of food, in the subsidies and the types of food that we promote, and the widespread ready availability of cheap, nutrient-poor, calorie-dense food.